Welcome to Glucose. Hey guys, today we will talk about pleural effusion. A pleural effusion is a collection of fluid abnormally present in the pleural space, usually resulting from excess fluid production and/or decreased lymphatic absorption. It is the most common manifestation of pleural disease, and its etiologies range in spectrum from cardiopulmonary disorders and/or systemic inflammatory conditions to malignancy. At first, we will mention a brief of anatomy of pleura. The pleural space cavity in a healthy patient is a potential space sandwiched between the parietal and visceral pleurae. The parietal pleura completely lines the inner chest wall surface of the thoracic cavity, inclusive of the bilateral medial mediastinum, the subcostal left and right diaphragmatic leaflets, and the innermost muscle surface of the ribs and associated musculature. The visceral pleura tightly envelopes both lungs completely, folding into the interlobar fissures, meeting the parietal pleura at the hilar root of the lungs. The right and left pleural cavities are separated in healthy people by the anterior and posterior mediastinum. Concerning etiology of pleural effusion, the normal pleural space contains approximately 10 milliliters of fluid, representing the balance between hydrostatic and oncotic forces in the visceral and parietal pleural capillaries and persistent sulcal lymphatic drainage. Pleural effusions may result from disruption of this natural balance. Presence of a pleural effusion heralds an underlying disease process that may be pulmonary or non-pulmonary in origin, and furthermore, that may be acute or chronic. Although the etiologic spectrum of pleural effusion can be extensive, most pleural effusions are caused by congestive heart failure, pneumonia, malignancy, or pulmonary embolism. The following mechanisms may play a role in the formation of pleural effusion: altered permeability of the pleural membranes. Example, inflammation, malignancy, pulmonary embolism. Reduction in intravascular oncotic pressure. Example, hypoalbuminemia due to nephrotic syndrome or cirrhosis. Increased capillary permeability or vascular disruption. Example, trauma, malignancy, inflammation, infection, pulmonary infarction, drug hypersensitivity, uremia, pancreatitis. Increased capillary hydrostatic pressure in the systemic and/or pulmonary circulation. Example, congestive heart failure, superior vena cava syndrome. Reduction of pressure in the pleural space due to an inability of the lung to fully expand during inspiration. This is known as trapped lung. Decreased lymphatic drainage or complete lymphatic vessel blockage, including thoracic duct obstruction or rupture. Example, malignancy, trauma. Increased peritoneal fluid with microperforated extravasation across the diaphragm via lymphatics or microstructural diaphragmatic defects. Example, hepatic hydrothorax, cirrhosis, peritoneal dialysis, movement of fluid from pulmonary edema across the visceral pleura, persistent increase in pleural fluid oncotic pressure from an existing pleural effusion, causing further fluid accumulation. The net result of effusion formation is a flattening or inversion of the diaphragm, a mechanical dissociation of the visceral and parietal pleura, and an eventual restrictive ventilatory defect as measured by pulmonary function testing. Pleural effusions are generally classified as transudates or exudates, based on the mechanism of fluid formation and pleural fluid chemistry. In some cases, it is not rare for pleural fluid to exhibit mixed characteristics of transudate and exudate. Concerning transudates, transudates result from an imbalance in oncotic and hydrostatic pressures. Transudative effusions are usually ultrafiltrates of plasma squeezed out of the pleura as a result of an imbalance in hydrostatic and oncotic forces in the chest. However, other mechanisms of injury may include upward movement of fluid from the peritoneal cavity or, in iatrogenic cases, direct infusion into the pleural space from misplaced or even migrated central venous catheters or nasogastric feeding tubes. Transudates are caused by a small defined group of etiologies, including the following: 1. Congestive heart failure. 2. Cirrhosis. Hepatic hydrothorax. Atelectasis may be due to occult malignancy or pulmonary embolism. Hypoalbuminemia. Nephrotic syndrome. Peritoneal dialysis. Myxedema. constrictive pericarditis, urinothorax, usually due to obstructive uropathy. Cerebrospinal fluid, CSF, leaks to the pleura in the setting of ventriculopleural shunting or of trauma surgery to the thoracic spine. Durapleural fistula, rare but may be a complication of spinal cord surgery. Extravascular migration of central venous catheter, concerning exudates produced by a variety of inflammatory conditions and often requiring a more extensive evaluation and treatment strategy than transudates. Exudative effusions develop from inflammation of the pleura or from decreased lymphatic drainage at pleural edges. The more common causes of exudates include the following: malignancy, most commonly lung or breast cancer, lymphoma, and leukemia. Less commonly, ovarian carcinoma, stomach cancer, sarcomas, melanoma. Pulmonary embolism, collagen vascular conditions, rheumatoid arthritis, systemic lupus, erythematosus, tuberculosis, TB, pancreatitis trauma, post-cardiac injury syndrome, esophageal perforation, fungal infection, intra-abdominal abscess, pericardial disease, Meigs syndrome. As a prognosis, the prognosis in pleural effusion varies in accordance with the condition's underlying etiology. However, patients who seek medical care earlier in the course of their disease and those who obtain prompt diagnosis and treatment have a substantially lower rate of complications than do patients who do not. Concerning clinical presentation, the clinical manifestations of pleural effusion are variable and often are related to the underlying disease process. The most commonly associated symptoms are progressive dyspnea, cough, and pleuritic chest pain. Dyspnea is the most common symptom associated with pleural effusion and is related more to distortion of the diaphragm and chest wall during respiration than to hypoxemia. 2. Cough. Cough in patients with pleural effusion is often mild and non-productive. More severe cough or the production of purulent or bloody sputum suggests an underlying pneumonia or endobronchial lesion. 3. Chest pain. The presence of chest pain, which results from pleural irritation, raises the likelihood of an exudative etiology, such as pleural infection, mesothelioma, or pulmonary infarction. Pain may be mild or severe. It is typically described as sharp or stabbing, and is exacerbated with deep inspiration. Pain may be localized to the chest wall or referred to the ipsilateral shoulder or upper abdomen because of diaphragmatic irritation. Pain may diminish in intensity as the pleural effusion increases in size, and the inflamed pleural surfaces are no longer in contact with each other. Extrapulmonary symptoms. Other symptoms in association with pleural effusions may suggest the underlying disease process. Increasing lower extremity edema, orthopnea, and paroxysmal nocturnal dyspnea may all occur with congestive heart failure. Night sweats, fever, hemoptysis, and weight loss should suggest TB. Hemoptysis also raises the possibility of malignancy, other endotracheal or endobronchial pathology, or pulmonary infarction. An acute febrile episode, purulent sputum production, and pleuritic chest pain may occur in patients with an effusion associated with pneumonia. Concerning diagnosis of pleural effusion, it includes 3 points. At first history, a detailed medical history should be obtained from all patients presenting with a pleural effusion, as this may help to establish the etiology. For example, a history of chronic hepatitis or alcoholism with cirrhosis suggests hepatic hydrothorax, or alcohol-induced pancreatitis with effusion. An occupational history should also be obtained, including potential asbestos exposure, which could predispose the patient to mesothelioma or benign asbestos-related pleural effusion. After that, physical findings in pleural effusion are variable and depend on the volume of the effusion. Typically, there are no clinical findings for effusions less than 300 milliliters. With effusions greater than 300 milliliters, chest wall pulmonary findings may include the following: dullness to percussion, decreased tactile fremitus, and asymmetrical chest expansion, with diminished or delayed expansion on the side of the effusion. These are the most reliable physical findings of pleural effusion. mediastinals shift away from the effusion. This finding is observed with effusions greater than 1,000 milliliters. Displacement of the trachea and mediastinum toward the side of the effusion is an important clue to obstruction of a lobar bronchus by an endobronchial lesion, which can be due to malignancy or, less commonly, to a non-malignant cause, such as a foreign body obstruction. Diminished or inaudible breath sounds egophony, known as E to A changes, at the most superior aspect of the pleural effusion. Pleural friction rub. Other physical and extrapulmonary findings may suggest the underlying cause of the pleural effusion. Peripheral edema, distended neck veins, and S3 gallop suggest congestive heart failure. Edema may also be a manifestation of nephrotic syndrome, pericardial disease, or, when combined with yellow nail beds, the yellow nail syndrome. Cutaneous changes and ascites suggest liver disease. Lymphadenopathy or a palpable mass suggests malignancy. Finally, concerning investigations. On talking about laboratory investigations, laboratory testing helps to distinguish pleural fluid transudates from exudates. However, certain types of exudative pleural effusions might be suspected simply by observing the gross characteristics of the fluid obtained during thoracentesis. As normal pleural fluid. Normal pleural fluid has the following characteristics: clear ultrafiltrate of plasma that originates from the parietal pleura, a pH of 7.60 to 7.64, protein content of less than 1.5 grams per liter, then 2%, 1 to 2 grams per deciliter, fewer than 1,000 white blood cells, WBCs, per cubic millimeter glucose content similar to that of plasma lactate dehydrogenase, LDH, less than 50% of plasma distinguishing transudates from exudates. The initial diagnostic consideration is distinguishing transudates from exudates. Although a number of chemical tests have been proposed to differentiate pleural fluid transudates from exudates, the tests first proposed by Light et al. Have become the criterion standards. The fluid is considered an exudate if any of the following are found, which called Light's criteria: ratio of pleural fluid to serum protein greater than 0.5, ratio of pleural fluid to serum LDH greater than 0.6, pleural fluid LDH greater than 2/3 of the upper limits of normal serum value. The fluid is considered a transudate if all of the above are absent. In measuring pleural fluid LDH, glucose and pH, pleural fluid LDH levels greater than 1,000 IU per liter suggest empyema, malignant effusion, rheumatoid effusion, or pleural paragonemiasis. Pleural fluid ELDH levels are also increased in effusions from pneumocystis jirovecii, formerly P. carinii pneumonia. The diagnosis is suggested by a pleural fluid serum LDH ratio of greater than 1, with a pleural fluid serum protein ratio of less than 0.5. In addition to the previously discussed tests, glucose and pleural fluid pH should be measured during the initial thoracentesis in most situations. A low pleural glucose concentration, 30 to 50 milligrams per deciliter, suggests malignant effusion, tuberculous pleuritis, esophageal rupture, or lupus pleuritis. A very low pleural glucose concentration, i.e., less than 30 milligrams per deciliter, further restricts diagnostic possibilities to rheumatoid pleuritis or empyema. Pleural fluid pH is highly correlated with pleural fluid glucose levels. A pleural fluid pH of less than 7.30 with a normal arterial blood pH level is caused by the same diagnoses as listed above for low pleural fluid glucose. Additional laboratory investigations include 1. Pleural fluid cell count differential. If an exudate is suspected clinically or is confirmed by chemistry test results, send the pleural fluid for total and differential cell counts, gram stain, culture, and cytology. Pleural fluid lymphocytosis, with lymphocyte values greater than 85% of the total nucleated cells, suggests TB, lymphoma, sarcoidosis, chronic rheumatoid pleurisy, yellow nail syndrome, and chylothorax. Pleural lymphocyte values of 50 to 70% of the nucleated cells suggest malignancy. Pleural fluid eosinophilia, PFE, with eosinophil values greater than 10% of nucleated cells, is seen in approximately 10% of pleural effusions and is not correlated with peripheral blood eosinophilia. PFE is most often caused by air or blood in the pleural space. Blood in the pleural space causing PFE may be the result of pulmonary embolism with infarction or benign asbestos pleural effusion. PFE may be associated with other non-malignant diseases, including parasitic disease, especially paragoniomyces, fungal infection, coccidioidal idomycosis, cryptococcosis, histoplasmosis, and a variety of medications. Two pleural fluid culture and cytology cultures of infected pleural fluids yield positive results in approximately 60% of cases. This occurs even less often for anaerobic organisms. Diagnostic yields, particularly for anaerobic pathogens, may be increased by directly culturing pleural fluid into blood culture bottles. Malignancy is suspected in patients with known cancer or with lymphocytic exudative effusions, especially when bloody. Direct tumor involvement of the pleura is diagnosed most easily by performing pleural fluid cytology. 3 tumor markers, such as carcino, embryonic antigen, Dusilius-1, and mucin, are suggestive of malignant effusions, especially adenocarcinoma, when pleural fluid values are very high. 4. Measure pleural fluid amylase levels if a pancreatic origin or ruptured esophagus is suspected. 5. Measure triglyceride and cholesterol levels in milky pleural fluids when chylothorax or pseudochylothorax is suspected. Concerning diagnosis of tuberculous pleuritis, adenosine deaminase ADA activity of greater than 43 units per milliliter in pleural fluid supports the diagnosis of tuberculous pleuritis. However, the test has a sensitivity of only 78%. Therefore, pleural ADA values of less than 43 to 50 units per milliliter do not exclude the diagnosis of TB pleuritis. Interferon gamma concentrations of greater than 140 picograms per milliliter in pleural fluid also support the diagnosis of tuberculous pleuritis. Unfortunately, this test is not routinely available. Concerning imaging modalities, 1. Chest radiography. Effusions of more than 175 milliliters are usually apparent as blunting of the costophrenic angle on upright postero, anterior chest radiographs. 2. CT scanning. A study involving consecutive patients with hepatic hydrothorax indicated that hepatic hydrothorax virtually always presents with sites that can be revealed by ultrasonography or computed tomography, ZT scanning. Point-of-care bedside ultrasonography has become the standard of care in many facilities. Also see pleural effusion imaging. Chest CT scanning with contrast should be performed in all patients with an undiagnosed pleural effusion, if it has not previously been performed, to detect thickened pleura or signs of invasion of underlying or adjacent structures. 3. Ultrasonography. Ultrasonography has been reported to have outperformed CT scanning in the identification septated pleural effusion. Finally, thoracentesis should be performed for new and unexplained pleural effusions when sufficient fluid is present to allow a safe procedure. Concerning treatment of pleural effusion, transudative effusions are managed by treating the underlying medical disorder. However, regardless of whether transudative or exudative, large refractory pleural effusions causing severe respiratory symptoms can be drained to provide symptomatic relief. The management of exudative effusions depends on the underlying etiology of the effusion. Pneumonia, malignancy, and TB cause most exudative pleural effusions, with the remainder typically deemed idiopathic. Indications for urgent drainage of parapneumonic effusions include 1. Frankly purulent fluid, 2. A pleural fluid pH of less than 7.0 to 7.1, 3. Loculated effusions, 4. Bacteria on gram stain or culture. For malignant pleural effusions, malignant pleural effusions usually signify incurable disease with considerable morbidity and a dismal mean survival of less than 1 year. For some patients, drainage of large malignant effusions relieves dyspnea caused by distortion of the diaphragm and chest wall produced by the effusion. Such effusions tend to recur in more than 90% of patients, necessitating repeated thoracentesis, pleurodesis, or placement of indwelling tunneled catheters. Drainage systems using tunneled catheters allow patients to drain their effusions as needed at home. For tuberculous pleuritis is typically self-limited. However, because 65% of patients with primary tuberculous pleuritis reactivate their disease within 5 years, empiric anti-TB treatment is usually begun pending culture results when sufficient clinical suspicion is present, such as an unexplained exudative or lymphocytic effusion in a patient with a positive PPD finding. For chylous effusions are usually managed by dietary and surgical modalities. However, studies suggest that somatostatin analogs also may help in reducing the efflux of chyle into the pleural space. Concerning surgical treatment, surgical intervention is most often required for parapneumonic effusions that cannot be drained adequately by needle or small bore catheters. Surgery may also be required to establish a diagnosis and for pleural sclerosis therapy of exudative effusions. Pleurodesis by insufflating talc directly onto the pleural surface using video-assisted thoracoscopy is an alternative to using talc slurries. That's all about pleural effusion. Thanks for listening, and see you guys in the next video.